Welcome aboard.
Please welcome to the stage Axios healthcare editor, Tina Reed.
Welcome, everyone. Thank you so much for being here. I'm very excited to introduce our event, Bolstering the Health Preparedness Workforce. The pandemic challenged our system like never before, and it gave us critical lessons in the importance of supporting a robust healthcare workforce, not only to respond to current health crises, but to prepare for future threats. Over the next hour, we are going to discuss a very timely topic, how to retain a resilient and prepared healthcare workforce. Don't forget to watch and follow along with today's conversation on social media with the hashtag Axios Events. And with that, let's get started with our first guest who oversees the United States Health Resources and Services Administration. Please welcome Administrator Carol Johnson. Thank you so much for being here today. I wanted to start with the news that came out yesterday about just how much we're spending on healthcare in the U.S. By 2031, we're looking at $7.2 trillion, nearly 20% of the U.S. GDP. So just to start, when we think about those kind of numbers, what role do you play in mitigating that? What challenges does that put to your job?
Well, thanks for the question, Tina, and thank you so much for having me and for having this conversation about the healthcare workforce. And thank you. I thought this might be like a presidential debate where we'd have to stand down here, but our role at the Health Resources and Services Administration is really investing in making sure that we build the next generation of the healthcare workforce and that we're helping to deploy the workforce in the places where it's needed most. And so much of our work is really focused on primary care. We run community health centers, 1,400 health centers in 15,000 sites around the country that provide healthcare regardless of the patient's ability to pay. So we are really helping to make sure that that footprint exists for everyone. And at the end of the day, if we're doing primary care well and right, we can help mitigate some of those larger cost issues because so much of what we see are chronic conditions that are ignored or untreated for a really long time, expensive end-of-life care, all those types of things, better primary care, better support for when people are, discharged from a hospital, all those types of things are critical to making sure that we can address the issues you raise.
And there are so many challenges right now. When we think about it, we've got a burned out workforce. They're strained from the COVID response, as well as employee shortages. We've got an aging population, an opioid crisis, a mental health crisis, maternal mortality, concerns about preparing for the next potential pandemic. And AI is going to take over the world, apparently. How do you think about all of this as you're creating a $13.3 billion budget proposal where you're not going to get everything you asked for? How do you maximize impact?
Yeah, it's a terrific question. I think that what we need to do is be as strategic as possible about the resources that we have and figure out how to best leverage our dollars. And part of that is recognizing, where is the market going to respond and where do we need to fill critical gaps? And for us, that really is about how do we build a primary care workforce? How do we build a pipeline to make sure that diverse young people are encouraged and get exposure to health professions and get the support they need to have the opportunity to make the choice to join health professions, and that we sort of wrap around folks to be able to support them at the times when being a health professional in training is really expensive. It's expensive to go to medical school. It's expensive to go to any health profession school. It's expensive to support yourself when you're in clinical training. So we do loan repayment. We do stipends to support people in clinical training. And then one of the critical things that is often overlooked is that when the healthcare workforce is strained and overburdened, it's hard to get people to become faculty, right? Because you can make more money, or your employer is encouraging you to have more billable hours. So how do we make sure that we're creating pathways to support people becoming faculty, and not just in the classroom faculty, but those clinical preceptors, the oversight, the support, the mentoring when you're in clinical training? Because without that, we see way too much turnover of people who just don't feel like they were supported. You know, those early years when you're a nurse in an ICU, it matters that you have a skilled expert who's there, a seasoned expert who can help you kind of learn the ropes.
And how do you get those people to get
So what we invest in is, we have traditionally invested in building the faculty loan repayment programs, building the support to make it possible to encourage people to take on those roles. But over the last couple of years in the Biden-Harris administration, we've said, that's necessary but not sufficient. And what we need to do is sort of restructure some of our funding to make sure that we are actually recognizing that faculty is that whole continuum, and that we need to support and provide ways to encourage people to become clinical faculty. And then we have built out our loan repayment programs. Thanks to the President's support in the American Rescue Plan, our loan repayments are at historic highs. There are 20,000 clinicians practicing in high-need communities today because of our National Health Service Corps loan repayment program. We have another 4,000 folks coming in through our Nurse Corps programs. All of these initiatives are really about helping to get people into the health professions and then helping them stay. What we find is if you can encourage someone or support someone to train or do residency in a community that's high need, or rural communities, people tend to stick, and that's what's really a valuable investment for us.
We saw a lot of burned out workers during the pandemic because it's a hard job at times. How do you get people to even want to go into the profession to begin with?
Yeah, two things. One, I'll just say for a long time, our investments in the healthcare workforce have been appropriately, but also have been focused on growing and diversifying the workforce, helping to encourage people to practice in high-need communities. For the first time in the American Rescue Plan, we got new resources to invest in the health and well-being of the current workforce. And so really focused on retention. And so we have been able to invest in, that's not just about making sure people have direct access to mental health services. That's important, and that's what we're doing with those resources too. But so much of what clinicians tell us is it's also about the work environment. If your work environment is repetitive and stressful and there's a lot of paperwork, and that adds to the weathering on healthcare workers. And so we need to make sure that we're investing in those types of supports as well.
Can you describe some of those? I mean, you were just mentioning AI had been floated as an idea of how to take down some of this administrative work that is slowing providers down.
Yeah, I've had the opportunity to meet with a number of primary care residents, right? So we support programs like our Teaching Health Center GME program, where we sort of reorient graduate medical education to center it around a community-based setting like a health center, as opposed to just being in an acute care hospital. And then, so therefore we're training people in the settings we want them to practice in, and they get exposure to the range of community needs. And so when I met with, actually I was with Chairwoman McMorris Rogers at a teaching health center in Spokane, Washington, and all of the teaching health center residents at that program were either from rural areas or were intending to practice in rural areas. It's exactly what we want to be doing. But they said, choosing primary care is hard because the administrative burden is hard. They called it their inbox problem, right? Where you basically spend a lot of time referrals and managing referrals to providers, on managing incoming and outgoing with insurance companies and the like. What was really helpful to them was that the teaching health center, because it's a health center, there are community health workers, there's social workers, there's the community workforce that we invest in to make sure that there's people who can follow up and keep their patients connected to care, connected to services, can connect them to things like transportation, so critical. Community social services like health, like childcare services. It's hard to go to a primary care. It's hard for me to take time off to go to a primary care appointment, and I have all the privilege in the world to be able to do that. Imagine if you lose hours at work and you have childcare and you need to take 3 buses to get there. Those are the kind of things that we're trying to solve for.
One of the big challenges coming out of the public health emergency is that we're seeing Medicaid redetermination happening across the U.S. I know HRSA directed $4.5 million in funding to address potential coverage gaps. What does that mean, and what other tools do you have in your arsenal?
Yeah, so look, again, we are in so many communities, particularly communities that were hard hit by the pandemic, Black and brown communities all over this country. Health centers are the trusted community resource. But if people who are otherwise eligible for Medicaid lose their Medicaid coverage, we're going to still see them in health centers, but the economic viability of that health center then becomes more challenging, right? Because those individuals are no longer reimbursable. So for the good of the patients, as well as for the health of our network of how we support people in under-resourced communities, we need to make sure that people who are otherwise Medicaid eligible remain enrolled. And so we're investing in all that we can through our health center networks to make sure that our enrollment assisters are helping people know how, it's been 3 years. You get a letter in the mail from the state or from your health plan. No, that is a very unfamiliar process now to people. I used to run the State Department of Human Services in New Jersey. We ran the Medicaid program. Redeterminations were hard in the regular times. So it's been 3 years since people have seen one of these. People lead complex lives, they move. And so finding people, making sure that they're staying enrolled, it's so critical. We also run the maternal and child health programs at the Department of Health and Human Services. So we're leveraging everything we can through our home visiting program, through our partnerships with states, and all of our network of Healthy Start grantees to make sure that we are ensuring that the families that we serve are connected to Medicaid during this really challenging time.
Speaking of economic viability of health centers, one of the big concerns for providers right now or for hospitals is the 340B drug discount program. Providers are complaining drug makers are applying restrictions on contract pharmacy sales for 340B, supposedly to force more transparency on how they use their savings. Where do you come down on this?
We have written several enforcement letters to drug manufacturers in response to these actions, and we are being sued by several drug manufacturers in response to our enforcement actions. So, we think that it's important that people have access, and we are in a host of litigation associated with this. I will say, the 340B program is an essential program for safety net providers. It's a little bit complex and it's a little opaque for some folks. We want to bring more transparency to the program. We want to make sure that the value of the program is clear to everyone involved, and so that we get more reporting from covered entities, so from hospitals and others, about how these resources are actually meeting the needs of their communities. So we have a proposal in the president's budget to do that, but there's no doubt that this is a critical program that is bringing resources to help stabilize and support the healthcare safety net.
Providers recently said that a policy change took place. Actually, they weren't sure, which cut off hospital outpatient clinics from 340B. Could you offer some clarity on what happened there?
Yeah, we're continuing to practice in this direction and making sure that everybody is clear on the fact that our practices remain as they were.
Okay. So when we look at what we need to give to providers to make sure that we have a resilient workforce in hospitals in particular. What are the areas we need to focus on most imminently? Is it our nursing workforce? Is there a certain piece of it that you think we need to prioritize?
Yeah, so it is, if you look at our budget proposals, where you see a real focus for us is on the nursing workforce, continuing to support the primary care workforce, but our new investments are really in the nursing workforce and behavioral health, as well as sustaining programs like our National Health Service Corps and other programs that support primary care. And then what we have in this year's budget that we're really excited about is a new initiative focused on healthcare innovation for the workforce. So how do we modernize some of our training programs? You know, there are some really interesting models around the country of ways that programs have used more holistic ways to think about admissions, brought community members in to think about how to design training programs so that they're more reflective of what communities need. We want to support those kind of models as well.
Okay. And you mentioned mental health. I know you've put a big request in for mental health services and supporting training and the workforce there. What does that look like? Where do you think we really need to improve?
Yeah, so we think that there are three big things that we need to do in mental health. We need to train more providers. We need to support providers with loan repayment and the kinds of supports that we've talked about. And we need to leverage the existing primary care workforce that, so we are investing in both the training of primary care. We're investing in training primary care residents in more mental health services, sort of changing the way primary care residents are trained so that mental health and substance use disorder are integrated into primary care training pediatricians, OBGYNs, supporting them when it comes to, you know, you can't meet a pediatrician today who doesn't say what they're seeing in their practice or mental health concerns of young people. And pediatricians will also say, those who have been in practice for a while will also say they didn't get enough training in this space when they were coming up in health professions training. So we want to focus on training more psychologists, social workers, marriage and family therapists, and peer support specialists and community health workers. Our budget proposal would train 18,000 new mental health providers. Then we want to invest in our loan repayment programs across the board. We have about 9,000 people in the National Health Service Corps getting loan repayment who are mental health and substance use providers. We run the STAR loan repayment program that's specifically focused on high need communities that have a high opioid death rate. And then we want to do the work that we're doing to change how primary care providers are trained so that there's more mental health there. And then our big proposal in the budget is to make mental health and substance use disorder a required service in health centers around the country and provide the resources to support that.
Well, I would love to ask you so many more questions about that, but we're out of time. Thank you so much, Administrator.
Thank you so much. Appreciate it.
Up next, our view from the top moderator and founder of Storyline, Chris Fritz.
Good morning, welcome everyone. Thank you for coming today, and a big thank you to our sponsor, the Infectious Diseases Society of America, for making this conversation possible. And joining me next is the treasurer of IDSA and an infectious disease specialist herself, Dr. Jeannie Marazzo. Dr. Marazzo. Okay. So, Dr. Marazzo, I am excited to talk with you today because I think as a physician, as a infectious disease specialist yourself, you have a really keen understanding about how public health works. And I wonder, what has been your role and the role of your colleagues in responding to infectious diseases, public health threats like COVID-19?
Sorry, we only have 10 minutes because that is a very loaded question. I'm really grateful to be here, and I'm also grateful to Administrator Johnson, who started to talk about a lot of the things that I'm going to talk about. So I'm going to talk a little bit about what ID doctors do, and pardon me if I make it sound a little bit like we're unicorns, but we sort of are. We are very unique, and we're unique from, I would say, two spectrums. So there's the spectrums of the pathogens that we deal with, and pathogens are the things that infect us, and they include bacteria, viruses, fungi. If you've watched All of Us, not All of Us, was it All of Us? The most recent HBO,
Yes.
The Deadly Fungus, you know that fungi can also be bad. So bacteria, viruses, fungi, and then some other more exotic things. So a huge spectrum of pathogens that impact the quality of people's lives. Some things are really familiar to people. COVID, of course, is a household word, but everybody knew about influenza, everybody knew about strep, everybody knows about staph and the horrible infections you can get. So all kinds of things. So the spectrum of the pathogens is very wide, and the settings in which they occur are also very diverse. So you've got daycare where kids can get a lot of diarrheal or viral infections.
Amen.
You're very familiar with that. You've got schools, you've got restaurant outbreaks, you've got hospital-associated outbreaks, which are particularly important. So you start to think about the spectrum of the pathogens, the spectrum of the settings where people come from, and then you think about the types of people who need to staff and work in all of those settings. So infectious disease doctors are dealing with the entire spectrum across the entire setting.
Okay.
They're also working in places that are as diverse as basic science labs. You've got some people who are in labs, running labs, trying to develop new antibiotics. We have a real problem with the antibiotic supply pipeline, not something we're going to talk about today, but you don't want to get a multi-drug resistant infection in a hospital, certainly in any hospital. So when you think about that, you've got people in the lab, you've got people in public health who are trying to convey all of those advances to recommendations and programs that can make an impact on the community. And then you've got people who are actually seeing patients and taking care of patients in the hospital. So a lot of people, a lot of problems, and a lot of challenges.
And a lot of different roles.
A lot of different
If
roles.
you're an infectious
Exactly.
disease specialist. And I wonder, how do those things break down geographically? How's it different across the country?
Right. So I'll give you a little bit of my experience as a person who works in Birmingham, Alabama, where we have over 80% of counties who do not have an infectious disease physician. Wow. And that is true throughout the United States. So infectious disease physicians tend to be concentrated in metropolitan, highly dense urban areas. And we'll come back to why we think that is. There are economic pressures as well as other pressures. So the challenge in a place like where I live is to get the kind of care that we provide, which, as I intimated before, can be highly specialized, particularly if you're a patient who has, for example, a transplant, right? I mean, that's another issue with advances in transplant medicine, advances in chemotherapy. I didn't mention this before. We're seeing patients who are really sick, living a very long time, and even more immunocompromised and vulnerable to these other infections. So a state like Alabama, where we do a lot of kidney transplants, we're one of the largest kidney transplant centers in the country, we're seeing people from all over the state who need care and need really specialized care. How do you do that when the infrastructure of the healthcare system in poor rural areas is really bad? You can do it by telemedicine, but honestly, there are times when you really want to see your doctor face to face.
Right.
So during COVID, we spent a lot of time, and we still spend a lot of time, working with physicians in rural or small town areas. It's not just rural, it's also very small towns, helping them navigate the complexities of taking care of these increasingly ill patients. Not everybody can get to Birmingham or to a city. It's really hard, and also telemedicine is great, but some places are not wired. We're here in one of the most wired places in the world. Alabama is a state where internet is not guaranteed, and it's not so easy for people to get on their phones and do a telemedicine appointment. And that's not unique when you think about rural America and poor America in general.
So then talk about, it sounds like we need more infectious disease specialists. So
We do.
what are the challenges to recruiting folks into what sounds like a really fascinating field with a lot of different...
I can sell it to anybody, but...
Right, a lot of different paths, right.
But sadly, what I can't do is to ensure that everybody is paid as well as they should be, that they won't suffer burnout, and that they can repay their loans. So Administrator Johnson mentioned the fact that med school debt is really staggering. The average is $250,000. Now people say, well, you're going to be a doctor, you can pay that back. The reality is that not all doctors are paid the same. So infectious disease doctors are actually paid among the lowest of any other categories.
So what's that look like?
Well, so it looks like, for example, if you are starting in an academic medicine job, and getting back to what she said about academics, as a professor, you're going to make probably around anywhere between $150,000 to $160,000, which again is a lovely salary. I don't want to make it sound like we're poorly paid, because that's not the message. But when you put it into the context of the indebtedness and the other specialties that are paid so much more. So you can have a great career as a surgeon, an orthopedic surgeon, do really cool, fun procedures if you're a nerd and you like that stuff, and be paid literally 5 to 6 times more than your average infectious disease doctor. So, or radiology.
And the same student debt load coming out
The
of
same student debt load. So the pressures are really strong to drive people into fields where they can be compensated. They can also have a much more control over their lifestyle. So we work hard. I mean, you saw during the pandemic that we're not the only people who worked hard, but but the pressures, the demands, and then the burnout. Right? We had a lot of negativity during the pandemic that did not make it look so appealing to go infectious diseases.
Right.
So a few things need to happen to fix that.
Few things need to happen, which brings me to my next question, which is kind of what kind of policy solutions are there here? What can government leaders do to ensure that we have a pipeline of smart, young, infectious disease doctors taking on the next challenges? Who knows what they will be, but there's certainly going to be something.
Yes, there will be something, I'm sorry to say. That's the one thing I can say with certainty. Everything else I will not predict. So you may have heard about the Preparedness Workforce Pilot Program, which was actually passed as a law as part of the Prevent Pandemics Act in 2022. However, that still needs to be funded by the Senate and House Appropriations Committee. It's a really important effort because it will help people repay those loans. There are provisions for loan forgiveness. So it really sort of signals to people how critical they are and how important they're going to be to the future of our ability to prevent and treat infectious diseases. The other thing is getting CMS, or the Centers for Medicare, to really address this issue of compensation. So if I spend 20 minutes with you in a hospital room, I get paid a lot less than if another specialist comes in to see you. Yes. So we're all reimbursed at different levels, and that doesn't feel good, and it also makes it hard to pay people adequately. So I have to scramble to find ways to pay my faculty. So we're trying to get those allocations increased and addressed. So those are just a couple things I think that are really important and hopefully will get us across the finish line.
So we have just about a minute left. What's the one thing you think everybody here should take away from our conversation today? What's the one key fact if they were going to take one thing?
Sure. I would say don't view infectious disease specialists as exotic or unique. If you are going to be a patient at any time in a hospital or anywhere, you're probably going to see an infectious disease doc. If you have a transplant, again, we're doing great. If you have chemotherapy for cancer, you may have an infectious disease doc who becomes your best friend. So remember, we're trained as internists, so we are actually just like everybody else, cardiologists, pulmonologists, but then we do an additional 2 to 3 years to get to a place where we can take care of the problems that are coming along with all the other advances that we have in medical care.
All right, we'll have to leave it there. Dr. Jeannie Marazzo is an infectious disease specialist. She is the treasurer of the Infectious Diseases Society of America. Dr. Marazzo, thank you so much for joining us.
Thank you very much. It's a lot.
Welcoming back to the stage, Tina Reed.
Our next segment covers the topic of healthcare workforce preparedness from the provider's perspective. She is someone who has endured the long nights and, in her words, is a caretaker that takes care of the caretakers. Please welcome the Vice President and Chief Nursing Officer at nearby Howard University Hospital, Dr. India Medley. Well, thank you so much for being here and driving over.
Yeah.
I wanted you to start, for those who are not familiar with Howard University Hospital, can you describe it, how many beds, Who is it? Who is its target population? Where is it located?
Good morning, everyone. Howard University Hospital is a true legacy hospital, having its beginnings as Friedman Hospital in 1862, and that building still exists there on the campus of the university. It was built for newly freed slaves in 1862 by Congress. So the mission was established over 100 years ago, many years ago. And that mission continues now where we are located on Georgia Avenue, not too far from here. And our population in the communities that we serve. Even as the ward changes in its population existence, we still are there to serve the unserved and the underserved and those who are also have options for primary care and emergency services as well. Whomever lives nearby or far away, we're going to serve you.
Thank you. I appreciate that intro. So I wanted to start by talking about the big workforce issue that is on everyone's minds, which is the concern of the burnout of the workforce. Mm-hmm. Could you just start by defining what burnout is in your view?
Burnout is anxiety, okay? And what is anxiety? Anything that would produce stress, that there's an uncertain future, there's a sense of impending doom. Am I safe? Am I providing safety for my patients, my family, And so needing to work more, needing more and more of healthcare providers, especially nurses at the bedside, and nurses wanting to give more time and energy to it and actually providing it. And then it's that sense of extreme fatigue, physical, mental, emotional. And there brings to mind compassion fatigue as well.
Did you ever experience burnout?
I'm sure I did. But you just keep going. I pray for strength for every day as it came, because I'm there to serve the nurses there. And yes, there were days I was on the front lines at the bedside as well because it was needed. And to give support, to extend appreciation, assistance, resources, because people, especially our professionals, need to know they're valued, need to know that their journeys are understood, and that we are there for them.
And this was already a problem before the pandemic, but can you describe what was it about caring during the pandemic that was just so taxing for healthcare professionals?
The fear of the unknown. We have great respect and regard for our scientists, both local and national. Every day we were getting new instructions, directives, guidelines, it seemed. So making those adjustments, okay, but we weren't doing this yesterday or last week, are we okay? That kind of thing. And then, the fear of, or the uncertainty of, are we gonna have enough resources? I mean, we were getting PPE, the protective equipment or gear, gowns, even ventilators. I mean, things were just being delivered on a daily basis, sometimes frequently during the day. And we never ran out. We had the resources that we need, as well as our sister hospitals, and we were sharing as well, as much as we could. So that is enough to make someone have stress. And I know that many healthcare providers, not just nurses, felt like, I don't know if I can make it another day, but they would still get up and come to work. And I remember driving in one morning and there was no traffic. Now that was one thing about the pandemic, it was absolutely no traffic. That was a positive. My commute was much, much shorter each and every morning, but I'm saying to myself, look at me, I'm going in. And many other people at the beginning of the pandemic were going home. And we're going in to the hospital each and every day, and some days actually staying overnight,
Wow.
depending on the need.
So obviously the official public health emergency is over, but what has changed and what has stayed the same in terms of the experience for the workforce when you think about just some of these stressors that the pandemic brought on?
I think we're a lot wiser. You know, we don't think that, oh, good, great, this is over. Life is going back to normal. What is normal? You know, we're now at a different level, but I believe that we're wiser. And I'm very grateful for the science and the scientists, and most grateful for the God that gives the scientists all this information for us to be able to be healthy, you know? So, yeah, that's pretty much what's all involved with that, in that we're wiser, we're more compassionate, understanding journeys of one another, not just other nurses, but physicians. Physicians, we're part of a team, and we were all exhausted, you know. Are you okay? Can I get you anything? You know, can I cover you? You know, those kinds of things. We had, you know, radiology technicians, you know, everybody, phlebotomists, pharmacists, we were all in there together. We were just like a family, very much caring for each other and what the needs are, and wondering, hoping that it would end. But again, on this side of it, you know, we still are expecting, possibly, dare I say, another, you know, it could be another virus, you know, but we're going to be more prepared this time. And certainly the expectations that we'll jump on, you know, jump on the healthcare preventiveness bandwagon, if I could say that, you know, much sooner, much quicker.
Okay. One of the things we've written quite a bit about is this bottleneck that's happening in a lot of hospitals around the U.S. when it comes to being able to, you know, bring new patients in, discharge patients. Is that occurring at Howard, and what are you doing about it?
So the bottleneck, yeah, we're doing the best that we can, Tina. We're doing the very best that we can, because what's happening at Howard is not unique to what's happening at our sister hospitals here in the city and in the DMV. We're all on the same plight, and we reach out to each other, you know, hey, what are you doing about this? What would you recommend? This is what worked for us. What do you think? You know, and of course we're pulling down the literature every day. What's best practice? You know, what is evidence-based practice? And we're going to use that because we trust it.
Do you find yourself looking at different innovations, like trying to use technology to discharge somebody to their home rather than maybe to a nursing facility?
Right. Well, we've come to a time in healthcare where we don't always have that choice. You know, it depends on how is this care going to be paid for, you know? Mm-hmm. Who's the insurance provider, and what do they allow? And if there's anything that's not allowed, then we try to make that up with our services, you know, on an outpatient basis or, you know, something like that. But it does depend a lot on how long they stay in the hospital, where they go when they're discharged, and, you know, in my ideal world, I just think nurses should be, you know, part of that decision making too, you know, on those kinds of levels, you know, with insurance companies and in government and things like that, because we know what the needs are and we can speak to it and do our best to be advocates at every level.
Going back to pandemic preparedness, obviously we don't know what the next threat will be, and it won't be the exact same as what we saw with COVID.
Right.
So what sort of things are you doing to prepare, knowing that it's not going to be the same?
You know, Tina, that's a great question. We want everyone, every worker in our hospital, regardless of the discipline, to be prepared. So it was not like, okay, that's over, we can move on and relax. And it's not that we want everybody to be stressed out, but we just want everybody to realize that we've now taken it to another level, and this other level is the new normal. So we're going to continue to protect ourselves. We're going to continue to protect patients. When patients come in with comorbidities, we're going to be very keen to what they're showing, the signs and symptoms that they're showing, pull up our resources, and making sure that we're addressing it immediately. You know, I'm not familiar with this, but I know this. And being in an academic hospital, you know, has its great benefits in that regard, because we can pull on those resources immediately.
Are there any particular investments you're making? I know, like, I'm thinking back in Ebola days, everybody was getting those zero pressure rooms or whatnot.
Oh, absolutely. Every day. Yeah. We're making investments every day. You know, we're talking about durable medical equipment. We're talking about the advancing technology with not just IT, but with diagnostic instruments as well, especially, and for treatment. And bringing on individuals who have a track record of treating these kinds of things, bringing them on more in larger numbers to our hospital as part of the Howard University Hospital family.
Let's talk about bringing in talent. Can you talk about equity in the workforce? How do we retain and recruit and bring in a generation of talent that reflects the community where they are working in, especially considering the financial burdens they're taking on just to get their education?
Yeah, we have to be intentional about that and really have a relationship with our academic institutions, you know, the colleges of nursing, the community colleges, you know, that have, you know, nursing programs, really engaged and involved, going to visit them during their academic career, hiring them as externs every summer, which is what we're doing as well at Howard University Hospital, student nurse externs, you know, because that really gives them an advantage, you know, when they're going back to class, because they've seen it, they've touched it, you know, that critical thinking just goes to a much higher level. But about equity, we want to make sure that our patients know that their care providers understand them, you know, and that they care about them, and that I know what you need, and I'm gonna make sure that I provide that for you without any judgment, without any attitude. You know, I am here to be a part of your healing process. So we're intentional in that recruitment, in where we're reaching out to recruit, to visit universities, colleges, career days, things like that, and even high schools. You know, high school is not too early. And making ourselves available and accessible in programs like this to talk about, this is who we are, this is where we are, please come join our family. But we're being very critical too in who we hire, you know, because, you know, we want nurses, but we want more people, but we just don't want warm bodies as well. We want people who demonstrate that they understand the calling, you know, and the commitment and the lifestyle too. Yeah.
What have you found that has worked, or what has not worked when it comes to fighting burnout, improving retention of your nurses?
What has worked has been being very genuine with them, and not just saying, I understand, or not just saying, thank you. It's doing things. It's saying, listen, you need to take the next 3 days off, the next 4 days off. And they will immediately say, no, but we don't have enough staff, or we don't have enough this, or I committed to this or that. And we say, no, we've made provisions for the unit. Please, you take this time. It's just not just saying, I understand, but demonstrating that you understand. It's not knowing what they need to help them get through. It's being what they need to help them to get through it. We also have resilience programs, and we have a wellness program there at the hospital that has really focused on movement, like exercise, improving circulation and decreasing stress, massages, music therapy, jazzercise classes, things like that. They're offered on a regular basis there at Howard University Hospital. We're looking at nutrition, what we offer, what we provide. And I'm very much a part of the DC Department of Health's initiative, particularly that the CNOs and our sister hospitals are part of. And we're talking about resilience and wellness programs as well. And we're bringing all those things into our own hospitals for our staff, So, and of course we have the EAP programs. Anyone need counseling, anyone need any support, from a professional, even for your children or for your spouse or significant other. Very holistic in our approach because we understand the need, It's a human need.
Well, Dr. Medley, thank you so much for your time today.
Thank you so much. Thank you all. Thank you.
Introducing Axios senior policy reporter Caitlin Owens.
Good morning, everyone. Our final segment of the day is taking our focus over to Capitol Hill and what's being done around the issue of preparing the health workforce for the next big crisis, or even just the day-to-day demands of doing their job. Joining me next is one of the senators from Minnesota and a member of the Senate Help Committee, Senator Tina Smith. Welcome to Axios. So let's start talking a little bit by addressing what you guys have already done on this subject. I know that pandemic preparedness was part of last year's big spending bill at the end of the year. Can you talk about what you think some of the most important components of that package was?
Well, I think the most important thing that we have to sort of, first of all, just understand is the intense pressure that the healthcare workforce is under, both the mental health care workforces, really the whole thing. So the realities of an aging workforce were there before the pandemic, and then the pandemic really exacerbated that, made it so much more intense as people just burned out. And I also think a lot about the public health workforce that was under so much pressure as we went through this unbelievable experience. So what we have done for the most part is to think about the ways that we can support encouraging people to get into the field. And we do that primarily by addressing, by having loan forgiveness strategies that will make it more affordable, because we know that cost is a prohibitor for a lot of people who want to get into the field. And we also know that we have intense needs to diversify our workforce, and that this is another great way of accomplishing this by adding, providing loan forgiveness and other ways for people to make it more affordable. But that doesn't get us all the way there, right? There's still more that we need to do.
Well, thank you. You've provided a roadmap for the rest of our conversation today. Let's start talking about the public health care workforce specifically. As you said, the pandemic was hard on this workforce. We saw a lot of people leave it, and they haven't come back.
Right.
What are some of the roots of those challenges? Why did so many workers leave? And what are some of the policy responses Congress can have to fix that?
Yeah. Well, I think, again, it's important to realize how the public health workforce was under a lot of pressure beforehand. It's also important to remember that, I believe for decades we really have been underfunding the public health needs of this country. And that means that those folks on the front lines in the public health department of the city of Minneapolis or working in the Department of Health at the state of Minnesota have had really more than they could do, more demands on their time. And so they were kind of burned out before all of this happened. And there also, I think, has not been enough attention paid to, if you think sort of about the pipeline for career paths for people, not enough attention paid to encouraging people to think about public health as a career path. And that is, I think, if we don't address that, then we're not going to be having, young people, and especially people of color, diverse people, to be able to say, "Oh, I get it. That's something that would make a lot of sense for me. That's a way that I could do well." The University of Minnesota School of Public Health has remarkable programs that are really succeeding in bringing new people in, especially encouraging a diverse group of people to take on these challenges. And so we know that works. We just have to put our money where our mouth is on those programs.
Well, right, and I think part of the issue during COVID was, cultural, right? Where I think that there was a lot of animosity towards healthcare workers, and that made the job harder. So, is there anything policymakers can do to address that, or is that more of a societal issue that?
Yeah, I mean, it's a great question, and I think about that all the time. We experience this sort of remarkable polarization of something that should have been so basic, which is that in the midst of a public health crisis, we all come together. We all sort of figure out how to take care of ourselves together. I guess I sort of think 5 years from now, 10 years from now, with the perspective of history, we're going to be able to appreciate even more than we can today what a dramatic shift the pandemic created in our society. I don't think we really can even quite fathom it yet. And this that you're talking about, that kind of polarization and that animosity that was directed at people who just have a career purpose of wanting to make their communities healthier and safer, I think is a part of that. I think a lot about mental health and the impact of the pandemic on mental health, and in some ways how it made discussions of mental health less stigmatized. And to me, that is another thing that I'm going to be curious to see what that looks like, 10 years from now.
And we are going to circle back to that, but before we do, staffing shortages obviously aren't limited to the public health workforce. It's a system-wide issue. Are there a different set of solutions that are needed for the general healthcare workforce versus the public health workforce, or are they similar issues?
I think that they are similar, and the way I look at it is sort of like a three tiers. One, you have to be reaching out and encouraging people to get into the field, starting in middle school and high school. There's some great examples of career academy programs that are showing folks, young people, what it means to be in this field, whether they're going to go into maybe to start out as a nursing assistant and then become a physician's assistant before maybe pursuing a full-blown degree in nursing or becoming a doctor. So there's that piece of it. Then the second piece of it is making that education affordable, which we've talked about, the needs for loan forgiveness programs. And I particularly like those programs that target people who are going to go into fields where there are particular shortages or places where there are particular shortages. The shortage of providers in rural communities is really dramatic, and there's some good examples that we could talk about there. But then the last thing is that there is a real shortage of spots for people to get training. And if you think about nursing as an example, where there are great problems with just not enough people getting training, if I'm a nurse with experience, I can make way more money. I'm not going to make a lot of money, but I'm going to make more money practicing than I can teaching. And so if we can't resolve that issue and create more spots in schools of nursing, for example, we're not going to be able to have space to train the people that we need. It's interesting, I was just looking into this, Caitlin, before we were going to talk. In Minnesota right now, we have about a 17% vacancy rate across the board in healthcare fields. So think about the pressure that that's putting on our healthcare systems.
And I do want you to, what is the, yes, it's hard for the healthcare systems. Can you talk, it might be obvious, but what is the implication for patients if you and I need care from those systems?
Oh, well, it creates just a much more pressurized and challenging system. I mean, I think that in this country we have a lot of challenges getting people access to health care. I think healthcare should be healthcare is a human right, and there are many, many ways in which people just don't have access to care. But if you think about the challenges in a space where there aren't enough people working in emergency rooms, or you have to wait a long time to get an appointment, even if you're not struggling with lack of insurance or other barriers to care, it just creates a lot more challenge. And then I know that people who are in the field of health work so hard to provide good care, but if you're overburdened, you've got, so many people that you're trying to see in a given day, that's going to have an impact on you and on the patients that you serve.
Right. Right. And, before we talk more about what the committee you're on is doing, you've brought up mental health care a lot today. I know you've been open about your own struggles with mental health. What are some of the unique challenges in this field to making sure the workforce is adequately prepared and that people have access to it?
Yeah. Well, it is... the continuum of care for mental health care is very broad, and it starts with the kind of basic, preventative care that you'd want to see, all the way through, whether you're needing therapy or group therapy, whether you have a substance use disorder or behavioral health issue, having access to care in that field, to people who are struggling with really serious mental illnesses, and then all the way to individuals who really need inpatient care. And we have shortages of care all the way along that continuum. It is heartbreaking to hear in particular about young people who are having a mental health crisis. Their families are unable to take care of them. And I have spoken to families who've had their children in emergency rooms for weeks because there is not a place for them to go, an inpatient bed, especially for young people. So there's a challenge of access to care all the way along that continuum. I have been open about talking about my own experiences with depression when I was younger, because I was so blessed. I had an experience with depression when I was in college, and I was able to immediately get access to school-based care that helped me figure out how to navigate and ultimately get better. But today, that is not the case. Something like 1 in 5 young people will have a challenge, mental health challenge, but only 10% of them are able to get access to care. And again, we have the same systemic problems. We have shortages of providers. We have real problems with insurance companies and others sort of reimbursing care where they need to. We should have parity for mental health and physical health. And these problems, again, are exacerbated in poor communities and in rural communities.
Well, thankfully for all of us here today, you are on the Committee of Jurisdiction for a lot of these issues, the Senate Health Committee. Can you talk a little bit about what some of the work that the committee is doing and plans to do on any of these issues?
Well, let me mention a couple of things that I think are interesting and good to keep an eye on. The first is that Chair Sanders and Ranking Member Bill Cassidy have been working on this workforce shortage area, and we've been approaching it from the context of what we can do with community health centers, which are such an important part of the infrastructure for providing health care in community. And we have a bipartisan working group that is trying to figure out where we can find some common ground. I think there's big differences in terms of the scale or how bold we want to be in expanding access to care. But a big part of that is an agreement that we need to address issues around workforce. So I have sort of a stay tuned on that about where we might end up, but I'm excited. As I said, there's this working group that the chair and ranking member have put together, and I'm on that working group, and I'm excited about that. The second place where I think there's real opportunity is the reauthorization of the pandemic preparedness legislation, which we'll be working on. And there's lots of really creative and innovative ideas there, both around workforce and also around how we can address some of the other systemic challenges that we have. For example, how can we onshore more manufacturing of drugs in order to keep us all healthy?
Yeah, and I do want to drill down. As you said, there are some big ideological differences in these areas. One of them is funding. I know something you've brought up repeatedly today is loan repayment.
Yeah.
Is something like that, does that have the potential to be bipartisan, or is that a Democratic goal?
I think that it is, broadly speaking, a bipartisan goal, but the question is whether there is agreement that like stuff costs money. And the it will be a real challenge. We should just acknowledge it, to try to figure out how do you expand loan forgiveness programs when we will be living within the budget caps that the president and the speaker have negotiated. And of course, now there's talk on the House side about spending below those caps. So that will all have implications for what we're able to do.
Well, the pandemic itself has become very political, and especially the pandemic response. When we're talking about bolstering the public health workforce, I mean, is that something Republicans and Democrats can agree to do?
I hope so. I mean, I'm optimistic. You have to be optimistic. I wake up every day choosing to be optimistic, and so there's always going to be opportunities to make progress, and we just have to look for those opportunities. And I will just note as well that the head appropriator in Congress on the Senate side is Patty Murray, along with Susan Collins on the Republican side. Both of them have served for a long time on the Health, Education, Labor, and Pensions Committee. They both understand these issues very well, and that, I think, bodes well for being able to elevate this as a big priority.
Well, so spending and appropriations is kind of the talk of Washington lately. Would you say it's fair to say that a lot of these issues we're talking about today, mental health, public health workforce, just healthcare shortages, worker shortages in general, it sounds like the fate of these issues, at least the policy response, kind of hinges on how these appropriations talks go?
I think that's very true. I mean, we can pass bills that authorize spending, but if we're not appropriating money to accomplish the goal, then we're kind of, we're not making the progress that we need.
Well, and even policy riders, right? When we're talking about things that go with packages,
that's right.
That's usually how things get done lately around here.
Exactly. But I just want to say that there are so many examples of innovation and creativity that are happening at the local level that I think we can lift up. I think about the great activity that's happening at the University of Minnesota Duluth around training GPs to practice in rural communities. Some really great things happening.
Right. That is important to note, that healthcare is often local. Anyway, Senator, we are out of time. Thank you so much for your time with us today and your work around this.
Thank you.
Thank you.
Thanks so much.
Before we go, I want to give a quick thank you to our partner, Infectious Diseases Society of America, for making today's conversations possible. And before you go, a reminder to sign up for Tina and I's newsletter, Axios Vitals, at axios.com/newsletters. See you next time.
Great.
Thank you.
Yeah, thank you.